Okay, so we're gonna get into these chapters here. Um, Chapter 18 and 19 seems pretty simple and basic. Chapter 18 is talking about vital signs and monitoring devices. So definitely not anything new to you. And then chapter 19 is history taken, secondary assessment type of stuff. So, ongoing monitoring. And that's certainly not going to be anything new as well, stuff that you guys are already doing in some aspects. What we hope to do is draw your attention to some other more advanced and in-depth things to be looking for, asking about, and checking and monitoring. So I don't think we need to, you know, teach you how to do vital signs, but we're gonna hopefully focus you to pay more attention to them, to pay attention to the trends, and to focus more in depth and more advanced on these things. So, with that, um, the first vital sign we're going to talk about is pulse. Your book has four vital signs that they talk about, and that's pulse, respirations, blood pressure, and temperature. There are we're coming up with more vital signs and more things. Maybe they're not technically vital signs, but we're more things that we're checking and getting measurements on. In addition to those four, what are some other things that we're checking and getting measurements on?
Long sounds,
Okay.
pupils,
Okay.
Are you asking what vital signs we do as
Mm-hmm.
other than the normal?
Other than those four, what else are you guys checking for?
skin,
What kind of measurements? Something that's giving you concrete numbers.
Blood glucose,
There you go. Blood glucose,
temperature,
temperature. That's one of the four. We'll add blood glucose for five. Um, any other things you guys are monitoring that are giving you numbers?
CO2 level,
CO2 levels. If you're putting capnography on, uh, you'll get a CO2 reading. Anybody have any more? Those were the. What was that?
respiratory rate.
Respiratory rate.
Yeah.
Yeah, that's the respiration. So the main four, the basic four, they have pulse, respiration, blood pressure, and temperature. Those are the basic four. And then as we are progressing in EMS, we are adding to that. So we've added finger sticks. So we're getting the blood glucose number with most of our patients now. We're also monitoring CO2 in a lot of cases. So we're getting that end-tidal CO2 number and waveform that we can put up now. So a couple more, maybe they fall into the advanced category. A couple more numbers for measurements that we have. Demetria alluded to a lot of things that are not concrete numbers. So there's a lot of assessment type stuff that we're going to check and listen to and look at, but those things don't necessarily come with a measurement of a specific number. So a lot of that is going to be left open to some sort of interpretation. If we're listening to lung sounds, looking at skin, pupils, different things like that. they're going to come with some degree of, interpretation as to cold versus hot or warm or room temperature, and then, equal versus unequal, and what people hear in lung sounds could be different. So those types of things are going to vary to some degree. But
Well, wouldn't like a GCS be like technically a vital too, because you are getting a concrete number?
it is. GCS is a concrete number. Um,
APGAR.
and APGARs are numbers. The RTSs are numbers. Those are assessment findings, which we, revel into numbers. So those are good. That was a good pickup too. So good things to add on to. But GCS for sure, we have to get that on every patient because that has to go in the report. Even if you're not basing your treatment on it, consciously basing your treatment on it, you should, because GCS kind of steers some of our treatment and some of our transport decision stuff. So if they have a pretty low GCS, then we should probably maybe not be taking them to Chowan or Albemarle. But those are good numbers too. So with these vital signs, the pulse specifically, when we're checking pulses, is anybody still actually feeling the pulses, or are we just slapping the pulse ox on and looking at the numbers for it?
Well, you got to make sure that your pulse rate that you're getting on the monitor it equals what you're actually palpating. Is it regular? Is it irregular?
Exactly. So we want to dive into this pulse rate just a little bit. Number one is I would encourage you to not trust the equipment. You could put the pulse ox on; it could give you a decent number, but equipment does malfunction. So I
And
would.
if the patient's hands are too cold, it's not going to read correctly anyway.
Right. Temperature is going to affect pulse oxes on the fingers, as well as, we know about, the nail polish and temperature and circulation and those types of things we have issues with. But just, wholeheartedly just trusting in the equipment, you want to verify that it's working properly. So the only way to do that is to actually palpate the pulses. So you need to feel, and then when you're feeling, you should be checking for a couple things. One is the rate. You want to verify that the rate, if you do have them on some type of monitor, whether it be a pulse ox or the cardiac monitor with the pulse ox on that what you're feeling manually is what the machine is picking up. So verify that they're within reason of each other, and then verify, like Derek alluded to, you want to see regular versus irregular. You can feel these pulses and figure out if it's a steady, constant beat, or if it's changing, if it's speeding up, slowing down, speeding up and slowing down, whatever it's doing. If it's doing something other than a steady, constant beat, then that's important information, and that should help you with your assessment. So if you're doing that and you get that, that should also steer you to get another measurement from these folks. What measurement would you want if you determine that this thing is a little irregular?
12 lead. 4
Yeah.
lead.
Yeah, you should be putting those folks on a 12 lead. And then when you get that 12 lead out, that'll show a much better picture of what you're feeling. So that would be a good course of action to take. So when you're feeling for these pulses, we want to verify the rate. We want to look at regular versus irregular, so steady versus changing, and then we're going to qualify the pulse. That you're going to have to, and this is where you're going to get subjective a little bit, because you want to give it some sort of quality. So a lot of times in your report, you will see, normal, strong, weak, thready. They use different words to qualify these pulses. And so you want to see if you can recognize that. If you feel a good, strong, steady pulse, then, things shouldn't be problematic for you. But if you're having trouble feeling it, if it's really weak, really faint, if you can't tell whether it's there or not, or it kind of goes and comes, then there's probably some issues going on, and that 12 lead is going to be important to you. So you get that, and we'll see, maybe get a more clear picture about what's happening. Does that make sense to everybody?
Yes.
Okay, good. As you go through the book, the book has a nice chart. If you're looking on 452 in the book, there's a nice chart on normal rates for different age groups. We've seen these charts throughout as we talk about different age groups. And of course, we have drilled into our head the adult numbers, and maybe we don't really know right offhand the younger age groups. We may not be as familiar with the normal numbers for them. So this chart on 452 will give you some normal number ranges for different vital signs. Which could be helpful for you. So let's use some 25-cent words here. How do we describe heart rates that are outside of our normal range? If we're talking about adults, what are we talking about as a normal range?
60 to 100, normal range.
Okay, so the normal range is 60 to 100. So if their heart rate is below 60, how do we describe that?
Bradycardia.
Okay, that's bradycardia. If it's above 100, then it's
Tachycardia.
tachycardia. So bradycardia less than 100, bradycardia is less than 60, tachycardia more than 100. And as long as it's between the 60 to 100 range, then we say they have a pulse that's in the normal limits. Is it normal for some people to be bradycardic?
Patient depending, yeah. Yeah, there's some people that you will come across, especially if they're quite athletic or they do a lot of running or something like that. You will see some people that have a normal resting heart rate that's below 60. So they could be in the 50s. They may be even into like the high 40s as a normal resting rate if they're quite the athlete or quite the runner and they do it regularly. You could encounter that. So the other thing to think about with these assessment type things and vital sign things that we're looking at is the normal for this particular patient. So every patient isn't the same. We do have these broad general categories for certain things. So just like the vital signs, we've got these broad general categories, but everybody's not going to fall into that, and they're still normal. So make sure that you understand and are asking some of those follow-up questions like that. What is normal for that particular patient? And in a lot of cases, the folks are going to know, especially like that, if they have some numbers that are kind of out of the range of normal, what we consider normal. then they'll probably know and tell you. So make sure you're asking. And if you're checking somebody and they have a heart rate of 50 or 48, but they're sitting there and they're talking to you and everything's good, you're probably going to have, you should, at this level in your career, you should have a whole lot of questions, some follow-up things that you would want answers to. Do you guys agree with that?
Yeah.
So it doesn't mean that we have to take any action. It doesn't mean that anything's wrong with them, but we just need to know that that is their normal. And as long as we know that, and as long as they're not complaining of things, then we can, monitor it, document it, take it as that's their normal. So that'll be good to go. If it's 48 and they're complaining of chest pains and difficulty breathing, things of that nature, then we've got some other actions that we gotta deal with. So keep those things in mind. All right. Respiratory rates. That's coming later. Let's talk about blood pressure first. Okay, so we have blood pressure. We're going to take blood pressure. In a lot of cases, how are we taking blood pressure?
The initial one is manual.
Okay, that's a good practice to use if you take an initial manual blood pressure, and then when you hook them up to the machines, then you have something to compare to see if your machine's wacky or not.
Mm-hmm.
Because we know how the fluctuation is between different machines. You can hook somebody up to like 10 different machines, you're going to get different numbers, but hopefully they're close and in the same ballpark. But the only way to know for sure is to do a manual one. So you can do that, and then as you get the readings from the machines, you can tell if things are changing or if your machine's in good working order. So what's important about blood pressure? What's the one big thing that we want to know?
That the systolic is at least 90.
Okay. Systolic is at least 90. Instead of worrying about that, let's worry about that 3-letter word that we've talked about a bunch.
Is this normal?
What's that?
Like, is it normal for is the pressure that we're obtaining, is it normal for the patient?
Right. Yeah, that's important. So a lot of people keep up with their blood pressures, and especially if they're on medications or have chronic diseases or illnesses, they may stay on top of that, and they'll know what it is, and you can certainly ask them what it normally would run and find out kind of where their normal usually is. There's a calculation when we get a blood pressure that we've talked about before, the
MAP,
that mean arterial pressure, and that we should kind of be running through our heads as we're seeing blood pressures in patients, especially patients that are sick. And I don't mean somebody that has a stomach virus. I mean patients that just don't look good, that have some potential shock-related things going on. We should be thinking about that number. Now, if you're using the cardiac monitors and doing blood pressures, it'll calculate it for you, and that's a nice feature on the monitor. Saves a little bit of time and thinking. But you guys try to keep that formula fresh in your mind, so that as you see blood pressures, and especially if you see blood pressures that are on the lower end of what we think of as normal, then you want to make sure that MAP is producing a good number. So for the MAP, what's the good number that we want?
At
65.
least,
Yeah, 65. So as long as the map is 65 or higher, then we can confidently say that the patient is perfusing, that they are getting that oxygen circulation through the body to the cells, and that the cells are able to get it, use it, and send their waste products out. So that's why it's important, and that's what we need to be focusing on. So not necessarily that we just have a systolic of 90, although that's a good rule. And typically, if the systolic is 90, the diastolic will be high enough to give us that 65 map. But, we can get that 65 map with a systolic lower than 90, and we cannot get that 65 map with a systolic higher than 90. So don't get caught in the trap of only focusing on a systolic of 90. Okay? Because you can play with numbers and see how it doesn't work out sometimes. All right. What else do we need to know about blood pressure?
Is it higher? Is it low?
What was that there?
Is it high? Is it low?
Okay. And what do we call high and low blood pressure?
Hypertension is 140 over 90 and above. Hypo, I believe, is
90 over 60.
Okay. So hypertension being higher end, hypo being lower end. And we have a little bit of qualifying measure there, although again, that's going to fluctuate some, and with the map being more important than a specific number of the blood pressure. So there's a thing we can do. It's called orthostatic blood pressure. Is anybody familiar with that, and can you explain it to me?
Yeah, it's where you have your patient stand up, take the blood pressure, sit down, take the blood pressure. And you should see, like, if they're positive orthostatic, then their pressure will drop.
Okay.
Correct?
Well, you start supine,
Yeah, you start laying down,
then sitting, then standing.
then sitting, and then standing. And what we're looking for at each point is a drop in the systolic blood pressure. And so if it drops at each stage, it's indicative of one of two problems. Do you know what the two problems?
Dehydration.
Dehydration is one. What was that?
I said dehydration.
Yeah, dehydration is one. That's one of the problems. What's the other problem?
I don't know about the other problems.
Okay, the other problem is going to be it's an indication of internal bleeding.
Oh,
Okay, so that's one of the reasons why orthostatic blood pressures is somewhat interesting and important for us, because we don't see internal bleeding in a lot of cases, and by a lot I mean all of them, because it's internal. So what it can help us to steer us to a speculation of internal bleeding or dehydration. Those are the two pathways that we would take if we do an orthostatic blood pressure. And your book has the process of what the correct process is for doing it, and this is how they describe it. Let me see if I can.
it's on page 459.
459.
Second paragraph from the top, at the top.
Yeah. And so it says you want them to lay down for 3 minutes, and then take the blood pressure, heart rate, and then have them. This one actually skips the sitting part, and then have them stand for 3 minutes, and then take it again. And so what you're looking for is a
20 millimeter drop in pressure or a 20 beat increase in heart rate, because that is a compensation mechanism. So if blood pressure is dropping, heart rate should be increasing to compensate. So you have, and then this version, this new printed version actually skips the sitting part, because it used to be a 3-step part of laying, then sitting, then standing. So now they're just saying lying down and then standing up. And so if we get that, then that should steer us either towards dehydration, depending on what's going on with the patient, or we should suspect potentially there could be some internal bleeding. All right. Regardless of which problem they're having, what's our treatment going to be for those?
Fluids.
Right. IV fluids. So if we do an orthostatic blood pressure, if we determine that they're positive for that, regardless of dehydration or internal bleeding, we should be using IV fluids to manage that patient. And then they'll have to do the ultrasound or whatever at the hospital to determine whether it is internal bleeding. And then they can treat from there. But our treatment will be the same regardless of which one it is. We're going to manage the patient. We're going to treat them for a couple things. One is we're going to treat them for volume loss. What's the big word for volume loss?
Hypovolemic shock.
Yes. So manage shock, watch for shock conditions, manage that, and fluid replacement is going to be our number one thing. So good deal with that. So now we'll talk about respirations. So respirations, typically there's several things that we want to know with respirations. Number one is the rate. So we want a number, and then we want to know what past the rate. What else do we want to know? Quality. Kind of describe that for me. What is it? What do you mean by quality?
Is it? I think it means like, is it normal? Is it agonal? Is it low?
Fast. Slow.
Okay, so Derek was saying normal, agonal. Let's use work. Are they working to breathe? Is this a labored type of thing? Is it a struggle? Those type of qualifying words could help you. So you could look at people and tell if they're breathing normally or if they're having to put some effort into breathing. If they are struggling to breathe, most of those patients' body position is going to tell you a lot, because people that are working to breathe are usually going to be sitting up straight as possible. They're probably not going to be laying down, and you'll see the work that they're putting into it. So that's going to be a key to us. If they're having to work, then we need to take some actions to get them some relief. So if you're at the A level, we've got a couple, we've got a few choices that we can do for them, and then you've got medic help at your disposal, and they've got a few more choices that they can do for them. So if your few choices don't work, and you're seeing that this patient's working to breathe, then you need to make sure that you're getting the medic help you need so that you can get them a few more choices. But rate is one thing, quality is one thing. So we want to see fast or slow, easy or hard. Is it easy for them to breathe? Is it hard? Are they struggling? Are they working? What else do we want to know about their breathing?
Hard breathing.
We talked a little bit about this already. We've hit on it. Anybody got anything? We're going to listen to these people, right?
Mm-hmm.
Okay. So we need to come up with some description of the long sounds that we're hearing. So we need to make sure we're listening and we can describe what we're hearing. We typically divide lungs. I typically divide lung sounds into two categories other than clear. So if it's a clear lung sound, then we'll hear that silent movement of air. It's just a in out movement of air. There's no other weird noises with it. But if it's not a clear lung sound, I try to divide it into two categories. So one would be constriction and the other would be fluid. So either things are getting tight or there's some junk in there. And depending on what you hear, that'll kind of steer you into which path you're going. And the reason I put them in those two categories is because that's kind of the two broad categories for treatments. If we're dealing with constriction, tightness, that type of thing, we have one treatment path. And if we're dealing with fluid in the lungs, that takes us in a different treatment path. So that's why I do that. Are you guys listening to lung sounds as you evaluate your patients, and are you able to describe those fairly decently or recognize the sounds that you're hearing?
Yes, I finally heard Ronchi the other night for the first time
Okay.
on a patient that had double pneumonia.
Mm-hmm.
Ronchi and wheezing for the first time.
Okay. All right. So wheezing is a constricted sound, and then ronchi is an obstruction sound. So there's something in there kind of obstructing the path. But that's good. It's a different sound though, isn't it?
Oh yeah.
Oh yeah. All right. On page 460 in your book, there's a nice picture with a lot of descriptive measures for lung sounds and breathing. There's a lot of body parts that you can look at and get clues from, and this picture kind of gives you direction as to how to look at folks and what things to look at. You know, not only the chest movement or the chest and shoulder movement, but also the abdominal region may be moving, the nasal flaring, just their sitting or standing position can give you some indications. That's a pretty good chart. And then underneath of it, there's a table that gives you all of the 50-cent words for EMS for breathing. So I've seen most of those words on tests. So if you are not familiar with the words in the 18-2 table in this book, I strongly encourage you to work on that. How many of us have ever used the word eupnea when we're describing the patient's breathing in our narrative?
Never, but I found out that is normal breathing last time.
Exactly. And how did you find that out, Derek?
I got the answer question wrong.
Yeah, that was a test question. And so the likelihood of us using that is probably not very, but for testing purposes, it's information that could make a difference for you. So just be aware of that chart and the terms that they're using on that chart. that'll help you out quite a bit. All right, so we talked about temperature. That was one of the 4 basic vital signs. Again, pulse, breathing, blood pressure, and temperature. 4 basics. We added a bunch of numbers and a bunch of measurements to that. But for temperature, there is a lot of controversy about how to take temperatures. There's at least 3 different temperature measurements that I'm aware of. So there's an oral temperature, an axillary temperature, and a rectal temperature.
Temporal temp too.
And you can do temporal now. That's what a tympanic. That's what most people are doing that as well. So that makes 4. They're scanning the forehead or just shooting it infrared and getting a measurement from that. There was one in the ear as well, and I guess they're reading kind of the same thing, or maybe not. One's temporal and one's tympanic. Tympanic's in the ear, temporal's on the forehead. Is that right?
Yes.
Most ambulances don't have those cute devices, so we're just used to the red and the blue one, right?
I'm used to the blue and not the red one.
Yeah. You know what the difference? Here's a joke for you. Off-color joke. You know what the difference between the red one and the blue one is?
The red one goes in the mouth. I'm just kidding.
The taste. That's terrible, isn't it? All right. So it's really going to depend on the doctors. A lot of doctors are particular about temperatures. We in EMS probably not so much. And the only time it's going to be really relevant is with hypothermic people, because we need that core temperature and warming them up nice and slow and easy. But in a lot of cases, we're usually doing an oral temperature for folks, and for fever type situations, I think the oral temperature will work fine. But there are certain doctors that won't accept anything other than a core temperature. So
Dr. Davis at Centera Mall.
All they want is a core temperature, right? Rectal only.
That's all Dr. Davis wants is.
Yeah.
Yeah.
So I've met a couple doctors that are that way, and they won't accept an oral temperature. They won't accept an axillary temperature. They won't accept anything except a core temperature. So you're going to be doing a rectal temperature if that's the way they are, because that's the only thing they want. So that's just kind of knowing who you're dealing with and what you need to do at that point. Just make sure if you're on the ambulance, make sure you have the 2 different colors if you're working on that. If you only have the one color, try not to stick them in the 2 different places. So tying in with temperature, if you guys will get in the mindset of this, tying in with a temperature is skin assessment. So if you can kind of work those 2 together, it may help you as you're doing your assessment. Temperature and skin are going to kind of correlate, because depending on the temperature, the skin's going to do certain things. So if the temperature is low, the patient is cold or hypothermic, how would you expect to find the skin?
Possibly cyanosis, of course, cold to the touch.
Okay.
Yeah, but the back of your hand.
Yeah. So cold to the touch, cyanosis. Those are. What was that?
Feel it with the back of your hand.
Yeah. Use the back of your hand. That's more sensitive than the palm in a lot of cases. So a couple things there. If they're hypothermic, now if they're warmer or in a hyperthermic state, how would you expect to find the skin?
Red. Blotchy, possibly.
Warm.
diaphoretic, possibly.
Okay, so could be pink or red to sight. It'll be warm or hot to the touch. It could be diaphoretic, meaning sweaty. So those kind of things, are things that we could steer our assessment as we take temperatures. If we're taking temperatures and we're getting something outside of what we would consider normal, when we do our skin assessment, hopefully we can correlate those two together. How about dehydration? If we have dehydrated patients, how's the skin going to be?
Tough.
Tough,
It may turn. It might be turgor when you pinch it.
right? Okay. And then what about
And
patients?
cold.
What about patients that are in a CHF type of state? What kind of skin condition would you expect there?
It's gonna be tight because of the fluid.
Okay, so fluid buildup.
Mm-hmm.
So what would we be seeing, especially out in the extremities?
Swelling.
Yeah, we should be seeing some edema out there, and we have a measurement for that, right? We push on it.
Fitting, yeah.
Yeah, to see how deep we can push, how long it stays, and doesn't kind of spring back to its normal state. So those types of things, if we have those conditions, if we're dealing with different medical conditions, the skin may be doing different things. So this is what I see mostly missed if I'm doing TSOPs and teaching people when they're doing their assessments in the learning environment and when they're doing their assessments in the TSOPs. The thing I see mostly missed is skin assessment. That just more times than not, that kind of pops up in my mind as the number one biggest miss. People focus on other things and they just bypass it. All right. Next thing is the pupils. What can the pupils tell us?
Head trauma,
Head trauma?
possible drug use.
Overdose.
Yep. Overdosing, drug use. So if we are looking at a drug use type of thing or an overdose type of thing, what kind of pupil look would we expect?
It depends on the drug.
Okay.
If narcotic is constricted,
Okay.
and if it's not a narcotic and it's a like cocaine, it'll be dilated.
So it could be either way with drug use. It just depends on the medication or the type of drug that they're on. Derek said head trauma. What could we expect with head trauma? Could we expect pupils to do with that?
One could be not reactive, one could be pinpoint, one could be dilated in the same
Okay.
patient.
Slightly unequal.
So we could see some differences. Pupils may not look exactly the same. One dilated, one constricted, that type of thing.
Until you have a patient has a fake eye.
Well, let me ask you this: could opposite pupils, one dilated, one constricted, could that be a patient's normal?
Yes.
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 Because I actually know somebody that works at Pasquotank. It's like that.
I had a guy that worked with me at the fire station, and we actually taught an EMT class, and that's when I discovered it, because we were talking about pupils and we were assessing everybody's pupils in the class, and he had one dilated and one constricted, but he had an old eye injury, and that was his normal.
Wow.
So just because you see differences, don't necessarily, you don't have to jump to conclusions or start freaking out because something's going on. You're worried about intracranial pressures or head traumas, ready to fly them off to a trauma center. But these are those follow-up questions that our next chapter is going to focus on, it, and that we need to qualify a lot of things before we start jumping to conclusions. Okay. And I'll give you guys a story about that when we get to the next chapter about jumping to conclusions. It's real good. So pupils, they can tell us some things about that. And then the rest of your chapter is talking about the advanced monitoring that we talked about with blood glucose, with capnography, and then the last thing we're going to talk about is the cardiac monitor. So the way the current standings are, cardiac monitoring, if you're doing continuous cardiac monitoring, that is a paramedic skill. So if you just put the monitor on and have a 4-lead on, or even if you hook the 12-lead up, if you leave it on and running the whole time that you're transporting the patient, that's a paramedic skill. Okay? Now you guys can put it on at the EMT level. You can put it on and get a 12-lead. At the AEMT level, you can also put it on and get a 12-lead. At both levels, you can use it to defibrillate patients that need it. But if you just leave it on and monitor throughout, then you're performing a paramedic skill. Okay? Does everybody understand that?
Even if you leave it on just for vitals?
You can leave it on for vitals. But if you have the 4-lead hooked up or the 12-lead hooked up while you're doing vitals.
Okay.
So you're saying get the 12 lead, then take all those leads off.
I wouldn't take them off, especially if you want to get another 12-lead. I'm just saying, and I'm not even telling you got to turn the machine off. I'm just telling you, in the eyes of the state, cardiac monitoring is a paramedic skill. So, and people could determine that to be, if you hooked them up to the 4-lead or the 12-lead and left it hooked up and the machine on the whole time, they could determine that to be cardiac monitoring. So be careful with that, so you don't get caught and somebody try to tell you that you're operating outside of your scope. It's just a little iffy hang up thing. But I don't see any problems. I don't see people having problems with it, but it's just one of those things. So the big thing we want to talk about is the cardiac part of it. You guys can do 12 leads. You can acquire the 12 leads. With the AEMT level, you guys get the privilege of being able to identify and recognize 6 cardiac rhythms. Okay? So those 6 rhythms are a sinus rhythm, a sinus Brady rhythm, a sinus tach rhythm, and then asystole, VFib, and VTach. Those are the 6 rhythms. So over the next few weeks, we're going to be showing you guys a lot of cardiac rhythms, and we're going to be getting you to the point where you know some rules about cardiac rhythms and you can identify those rhythms. The importance of it, and you're going to say, why do I need to know this? Who wants to know why you need to know this?
Because if you don't know what those are, you don't know when to call for additional help.
Okay.
Because you need to be able to identify abnormalities in those 6.
Right.
Whether it be elevation or something like that. Granted, we can't call it as ST elevation because we can't do that, but I know we can read what the monitor says.
Right. You can read what the monitor says. You just can't make any kind of interpretation on it. However, if your patient happens to be in VFib, you need to be able to recognize that for the simple reason of saving their life, right?
Right.
Right. Because what's the treatment for VFib?
AED shock.
Okay. You need to shock those people. And you need to perform CPR on those people. Because if you're seeing VFib, then your patient is technically dead. They're not going to be awake. They're not going to be responsive. You're not going to feel a pulse. But that is a shockable rhythm, so it needs to be treated with defibrillation. And you'll follow that up with the AHA guidelines for CPR. So recognizing those things is important because it's going to steer some of your treatments. All right. And what's the difference in treatment wise? What's the difference between VFib and asystole?
You do not shock asystole.
Right. You're not going to shock asystole. You're going to do CPR on them if you determine that it's a workable thing. You're going to do CPR on them. That's going to be your whole CPR code deal with your airway management, your IVs, your epi 1 to 10,000, all that good stuff. But
So I got a question.
okay.
All right, so like over here in Paquemmons or over there in Pasquotank, we do run A trucks and say that there is no paramedic level at all. And you get them from, let's say, VFib to AFib. What do we do? Do we just transport? And
Yes.
there's no medic available.
Yes, because
Okay.
you don't have a treatment for AFib.
Right. Okay.
You do have a treatment for VFib, and you are well within your scope to say this patient is in VFib. We're going to defibrillate them, and we're going to do CPR on them until we get a change. And if you defibrillate them, you could very likely get a change from VFib into something else. It may not necessarily go right back into a sinus rhythm. It may go to something else. Or it could start right back up as normal as ever. So the deck is open. The odds are, the options are unlimited in that aspect. But yeah, if you do get something back, and it's something other than VFib, and it's something workable, then yeah, you would transport at that point to get them to where they can get the treatment. If it happened to go from VFib to AFib, then you could go get them some treatment on that. Although you wouldn't be able to say they were in AFib.
Mm-hmm.
Right.
But then technically, let's say we got them back into, let's just say the monitor said AFib.
Yeah.
I know what AFib looks like. I mean, I've done this long enough to know what it looks like. But
Right.
I know I cannot call it. Like if we were to call and report, will we call and report stating that the patient is now in AFib on the monitor?
Yes, you would call in the report saying that the monitor is showing AFib, but you're not making that interpretation. You're reading what the 12 lead is showing you.
Right. Okay.
Right.
And what the monitor decided. You're not making an interpretation. So it's just a little bit of technicality and a little bit of, painting within the lines, but we'll get you through that stuff. What I do want to talk about real quick is some rules for sinus rhythms. I want to give you guys some rules for that, and I want to see if I still have it. Whiteboard. See if it's here. Can you guys see that? You may have to turn your camera on to see. I don't know.
Yes, I can see it.
Okay, good. So these are the rules for sinus rhythm. If you have a cardiac rhythm that falls within these parameters, then by definition, we would refer to that as a sinus rhythm. So the first thing that we want to look at is the rate. As long as it is the rate between 60 and 100, then it meets the rules for that. Once we determine the rate, we want to see if it's regular or irregular. So Derek said he's been doing this a long time and he knows what AFib is. And so if he knows what AFib is, then he knows that that is a extremely irregular rhythm. The next thing we're going to talk about is what the waveform looks like. So if you guys have your book available, this is all on page 470 in your textbook. If you don't have, good gracious, somebody tearing stuff up. So we'll talk about the waveform. So the P wave is, I tell you what, hold on just 1 second. Let me get somewhere else real quick. I've lost my ability to find myself. Let me switch to this real quick. Everybody see this on the page?
Yes.
Okay, this is the picture that's on 470 in your book. So this is what the waveform looks like. So let's talk about this right now real fast with the rules.
Cliff, all I'm seeing is the COA my course thing that you have going on. Maybe that's mine.
You don't see the PowerPoint?
No, I don't see the PowerPoint, sir.
Does everybody else see the PowerPoint?
No.
No, I just see the
No, all
little,
I see is a COA screen.
yeah, COA.
Well, what about? Okay.
Central 21.
Go ahead.
One's clear and available, last call.
Medic 21, you're going to be clear number 2323 at 1921.
You guys see a PowerPoint now?
Yes.
Yes.
Okay.
21.
Okay, here we go. This is the red and white squares is indicative of what your printer paper looks like in your cardiac monitor. So the way cardiac rhythms work is it's a measurement of time. And what we're looking for in these waveforms is we're looking at the shape of the waveform and we're looking at the measurement of time. So on your paper, you see some really small boxes, and then you see a little bit bigger box that's kind of bolder. Is everybody making those out?
Mm-hmm.
And then what you'll see is each one of those is a measurement of time. So the really small box is 0.04 seconds. Each one of those little small teeny tiny boxes is 0.04 seconds going across the page. And if you count them, you should have 5 of those little small boxes in one of those bolder, bigger boxes. So the way this stuff works is it works left to right, and you can see that there are, on this particular thing, there's a bunch of rows. So 1, 2, 3, 4, 5, about 30 rows top to bottom. So what you do is you just pick one line, one row, and go straight across from left to right. Each one of those little boxes in the row going across is 0.04 seconds. And each one of those bigger, bolder boxes is 0.2 seconds because it's 5 of the little boxes. So those are the time measurements. We're looking at 0.04 and then 0.2 for the big box. So we identify the waveform by letters. As you can see here, there's a P wave, which is the beginning of the cardiac waveform. And this gives you a mark here for the P wave. The P wave is indicating the atrial contraction in the heart. So when you see a P wave, that means that the atrium just contracted. And then that leads us into this QRS complex. You'll see Q at the bottom, R will be at the peak, and then S will be down low. So QRS complex, that's what we call it. And that QRS complex is representing the ventricle contraction in the heart. So P wave is atrial contraction, QRS is ventricle contraction, and then the T wave is the repolarization. So that's when everything is refilling. Does that make sense to you? Yes, no, maybe?
Yes.
Okay. That's what those things mean. So for a normal rhythm, if we're looking at a sinus rhythm, the P wave has to be upright and rounded like it is here. So it'll take that shape of rounded and upright. The QRS complex has a time duration. So from the beginning of the Q to the end of the S, as you can see the line that's marking the QRS interval, that time frame is 0.12 seconds or less. So that equals 3 of those little boxes or less for that to be a sinus rhythm. That complex has to be less than 3 little boxes. The PR interval, you'll see that marked on the bottom. That's the beginning of the P wave to the beginning of the Q. And that interval, we want that interval to be less than 0.2 seconds. So that would be 5 of those little boxes or 1 of the big boxes. We want it to be less than 0.2. For a sinus rhythm, you'll usually find that in the range of 0.12 to 0.2. And then when you have all of those things come together, you can identify this as a sinus rhythm. Anybody have any questions about that? So here's your rules. They're written out. A rate of 60 to 100 with the rhythm being regular. That means constant. That means when you look at the paper, it's evenly spaced out. No fast and slow, no skips, anything like that. It's just a constant regular thing. P wave present, upright, rounded, QRS complex as less than 0.12 seconds. PR interval less than 0.2 seconds. And then for every P wave that you see, you should see a QRS complex right after it. And for every QRS complex that you see, you should see the P wave right before it. Then you'll have a T wave after every QRS for the repolarization. And if you have all of these things in place, then you can refer to this as a sinus rhythm. So what do you think needs to happen to have a sinus Brady rhythm?
Gotta be less than 60.
Yeah, the only rule that we're going to change is the rate. The rate for a sinus Brady rhythm, the rate's going to be less than 60. All of these other things will still be in place. And on the other end, for a sinus tach rhythm, the only change is that the rhythm is going to be faster than 100. So we would have a rate, and typically for a sinus tach rhythm, we're going to have a rate between 100 and 150, because once it gets above 150, we're going to throw it into a different category. Does that make sense to you guys?
Oh, yeah.
Okay, so with those rules, those simple rules that we just gave you, I just told you how to identify half of the rhythms that you have to identify. So we just got 3 of them knocked out. So can you guys see this? It's a bunch of rhythms.
Yes.
I'm trying to blow it up for you. So the one that's on the screen, what I'll tell you is that typically when you see these strips like this, these strips are posted and they're in 6-second intervals. So this would be a representation from this end of the page to this end. It would be a representation of 6 seconds. Okay, so when we determine what the rate is, we're identifying the rate per minute. So if this is 6 seconds, how would we figure out what the rate is?
We would count the bars, each of the 5 blocks, all the way over to the 6-second mark, all the way to the end of the strip.
Okay, so
You can do up to 3 seconds and times it by 2.
So this is what we're going to do. We've got 6 seconds worth of strip here. So if we want to know what the heart rate is by looking at this strip, we're going to count these QRS complexes. Okay. So how many QRS complexes are there?
1, 2, 3, 4, 5, 6, 7.
Okay. And what did I say the QRS complex means? What's the heart doing?
Refilling, contract.
What's contracting?
The ventricle.
Yes, the ventricle is contracting when you see this QRS complex. So the P wave is the atrial contraction. The QRS is the ventricle contraction. So that P wave and that QRS is one heartbeat, right? So if we count these, we have 7 of them on this 6-second strip. How many 6 seconds are in a minute?
10.
So if we multiply these 7 heartbeats times 10, that
You
gives
got a
us
heart rate of 70.
That gives us a heart rate of 70. So by looking at this 6-second strip, this patient has a heart rate of 70. Okay, is that normal?
Yes.
So look at this rhythm. Are these QRSs evenly spaced? Do they seem to be happening on a regular interval? Are they about the same width apart from
No.
from the first one to the second one? Is it about the same distance from the second to the third, and then the third to the fourth?
Yeah, it's close, yes.
Yeah, it's a little bit off, but it's fairly close, right? Okay. And
so it's regular.
How wide is this QRS complex from the start to the finish? How many little boxes?
1.5.
Is it less than 3?
Yeah.
So that falls into the parameters, right? Because if we were to look at a sinus rhythm, this QRS needs to be less than 3 little boxes wide. So less than 0.12 seconds. And we have that here. All right. So these P waves, that's a P wave where the cursor is. Can you guys see my arrow?
Yes.
That's a P wave. That's a P wave. That's a P wave. P wave. So from the beginning of the P wave to the beginning of the QRS, how many boxes would you say?
Sorry.
About 5 or less.
Yeah, 4 to 5 is what it looks like to me. Start right here. So we got 1, 2, 3, about 4 boxes. 1, 2, 3, 4. So that falls into the parameters, right? As long as it's less than 5 little boxes,
Mm-hmm.
right? And we have a 1-to-1 ratio, right? 1 P wave, 1 QRS. 1 P wave, 1 QRS. So they're all here, right?
Yeah.
Okay. So by definition, for all those rules that I gave you, we have a rate of 70, which is between 60 and 100. This looks fairly regular. We have a QRS complex that's less than 0.12 seconds. We have a PR interval that's less than 0.2 seconds. And we have a P wave that's upright and rounded, and a QRS, and that we have 1 for each one, right? So what do you want to call this rhythm right here?
Sinus tack.
No, that's what's written on it.
I
What do
mean,
you call it?
sinus rhythm.
It's a sinus rhythm. That's what we would say, that this rhythm is a sinus rhythm.
Because the heart rate is 70. Okay.
What about this rhythm?
Hey, Cliff, hold on. I gotta sign out and sign back in because my screen's messed up.
Okay. I can get him back in.
It's gone, Cliff.
Yeah, I stopped it for just a second. I
Oh,
can't
okay.
I can't sign him back in if
Oh.
I'm looking at the other screen. I can't see all that at one time.
Well, I'm going to the restroom then.
You still there, Derek?
Yeah, I'm trying to figure out because it's like it won't let me exit out of the chat, but it won't let me see what y'all are seeing. All I see is just y'all's names.
Huh. Your names, you don't see the screen?
Yeah, all I can see is y'all's names. When I click on Monday Classroom, it won't pull it up.
What about now? Do you see the screen now with a rhythm on it?
No.
Huh.
Is there any way that you can, like, I guess, kick me out and then I'll try to sign back in?
Hell
There you
yeah.
go. Okay, it's working now.
You got it?
I think so.
Okay. I mean, I can kick you out.
Yeah, do that because I don't know what the hell it's doing.
Okay. Oh, wait. If I kick you out, it won't let you back in.
Oh, shit. Hold on. I'm going to do it. Hold on.
What's in your glass, Cliff?
Ginger ale.
Mm-hmm.
All right. You back?
Yeah, all right, it's working.
So here, let's go back to this. You guys see this strip now?
Yeah, I see it.
Yep. Too small.
She takes the example.
Okay, so let's assume that this is also a 6-second strip. What would your rate be on this one?
Heart rate be 50.
Heart rate would be 50 if this is a 6-second strip. So can we call this a sinus rhythm?
No, sinus Brady.
Okay, so if we can meet all the other parameters, this would be a sinus Brady rhythm. So do all the other parameters work?
Yes.
Okay, so QRS duration less than 3 little boxes. PR interval less than 5 little boxes. We have a QRS for the P's and a P for the QRSs. The T waves are afterwards on all of them. So if we meet all of those other parameters, this would be a sinus Brady rhythm at a heart rate of 50. All right. Do you guys see these 3 little marks at the bottom of this strip? So
Yeah.
between the first mark and the last mark is the 6 seconds.
Might want to start this way, please.
So what kind of heart rate would you be looking at?
About 130.
About 130, yeah.
Okay.
That.
Now so that puts us outside of the sinus rhythm and throws us into sinus tach if we meet everything else. Do we meet all the rest of the stuff?
Yeah.
Absolutely.
Okay. So the QRS is narrow enough. The PR interval is within limits. We have all the parts. The P waves, the QRSs, the T waves, they're all there. So all of this stuff works. It's evenly spaced. It looks pretty regular, right? So this we would consider to be a sinus tach rhythm at about 130. All right? Easy enough, right? So let's talk about the other 3 rhythms. So if we're dealing with VFib, what's happening with the heart?
It's shivering like it's not adequately pumping.
Okay. The heart is basically quivering, so there's no pumping process going on. The electrical activity is going crazy. So electricity is just flowing all over the place, but it's not organized. It's disorganized. And do you guys see this rhythm strip down here? Under the heart picture?
Yes.
That is indicative of a VFib rhythm. It is just total chaos. You will not see P waves. You will not see QRSs. You will not see T waves. You will just see craziness like this. So this is the fibrillation, the quivering. That's what it looks like on when we print a rhythm out. So just totally erratic, nothing discernible, none of the parts you could recognize. All right?
So if you see this, this is called VFib. And some people may refer to this as coarse VFib because there is a thing called coarse VFib and fine VFib. And fine VFib is going to look more like asystole. It'll have some erratic to it, but it'll just be really close to this steady line type of thing. So it's hard to tell the difference. The only way you can really tell the difference between fine VFib and asystole is change the amplitude on your monitor. But in most cases, we just treat it as asystole. So again, the treatment for VFib?
Shock.
Yes. Early defibrillation is key, so that they need to be shocked. If you see this rhythm or something that looks crazy like this, you should check your patient. You're probably not going to have a patient that's alert or responsive. You're probably not going to find a pulse anywhere, and you need to defibrillate them. This is VTAC. What's going on in the heart with VTAC?
Electrical problem.
It is an electrical problem. It's kind of like a runaway. The ventricle is contracting really fast, and in fact, it's happening so fast that it's not giving the heart any time to put any blood in the ventricle before it contracts again. So it's contracting so fast that it just can't pump blood. There's two types of VTAC, and there's two different kinds of ECGs that you'll see of VTAC. So two types of VTAC. One is VTAC with a pulse, and one is VTAC without a pulse. Okay, so depending on the patient, they could be in VTAC, but they could be awake and have a pulse, or they could not have a pulse. So you really need to assess your patient. If you see this on the monitor, you need to assess the patient and figure out which one they are. All right? If they are VTAC without a pulse, what are we going to do for them?
VFib. Compressions.
Yeah, we're gonna defibrillate them and treat them in the same manner as the VFib. The VFib and the VTAC without a pulse, exact same treatment. So defibrillate, CPR, those types of things. If it's VTAC with a pulse, they get a different treatment. And at the A level, what would you be doing for them at the A level?
Fluids.
Okay.
Keeping them warm.
What's one thing you can try to get them to do to
Or you can get them to vagal now.
yeah, you could try vagal maneuvers with these people. It may help. You may see some change on the monitor, but if not, you're gonna have the 12 lead. You're gonna have I would have defib pads ready in case they went from VTAC with a pulse to VTAC without a pulse. I would be concerned about that, and I would be ready for moving into a defibrillation mode. But as long as they have the pulse, IV and give them fluids for sure. Try some vagal maneuvers and monitor them for changes, because that's what I would be.
What's the vagal maneuvers?
There's a couple you can try. You know, you could have them kind of
strain, that straining sensation, like they're
Like blowing
lifting.
through a straw.
Yeah, like blowing through a straw, or they're lifting something heavy, or that you
Pooping.
could also put their face in cold ice water. That'll have the same
Kate
effect.
said, Kate said she used to have an athlete at when she was the whatever that I can't think what her job description was, but at the school that he would have to stand on his head.
Mm-hmm. Yeah. There's a bunch of different vagal maneuvers. If you look them up, you can see what they are. If you can get cold ice water, you can stick their face in it, and that'll have the effect. But the other thing is like trying to blow through a straw, or trying to lift something really heavy. That kind of sensation will do it. All right. So this is what the rhythm will look like. What you see down here at the bottom, these are the ventricle contractions. You can see how wide they are. You don't see any P waves. You don't see any T waves. All you're seeing is ventricle contractions. And that's what the rhythm is showing you. And those are in VTAC, they're going to be wide. You're not going to see, typically you won't see them in the less than 0.12 second range. They're going to be wider than that. And then the last one is asystole. What does asystole mean?
Dead.
Yeah,
No
but
heart.
what does it
No
mean
heart.
with the heart?
There's no electrical activity at all, right?
Right. There's no electricity in the heart at all. So the heart is not beating. Nothing is contracting because there's no electricity. So if you don't have a battery in your car, is your car going to start?
No.
No, it's not. So this is like cutting off the battery for your heart. There's no electricity, so there's no activity there. That's what this flat line means. It won't be straight flat across. There'll be some little waves and up and downs in it, just like you see here. If you guys have ever taken a strip on somebody that's dead, you'll see that it's not exactly flat, but it's pretty flat. You don't have any of the heart activity that we see in the other strips. So no P waves, no QRSs, no T waves. There's just no activity at all. Okay. So what's the treatment for asystole?
CPR.
Yeah. CPR, we'll do the whole code thing. Airway management, IVs or IOs, epi 1 to 10 every 5 minutes. See if anything changes. Probably won't. All right.
Yes, sir.
So those are your 6 rhythms that you are allowed to identify, expected to identify, and be able to treat. So that's the rules for them. As we go along in the next several weeks, we'll be discussing a lot more of this. We'll talk about it in the labs as well. You'll get a bunch of that. The other chapter is chapter 19, history taken, secondary assessment, reassessment stuff. This is going to talk to you about determining what's relevant in the history taking. People are going to give you history from their childhood. They could be 70 years old. They'll tell you they broke their arm when they were 6. And in most cases, that's probably not going to be relevant for us. So you guys are going to have to filter through what's relevant and what's not relevant, as far as asking those good follow-up questions that we talked about, determining what the patient's normal is. The chapter goes through all of your good mnemonics, the sample questions, the OPQRST questions, the DCAP BTLS questions. So you can get all of that stuff done. And the big thing that I find with
monitoring and reassessment and ongoing assessment is you guys are now at the level where you're going to start doing some interventions and doing some real treatments with medications. So the important thing that you want to know is what reaction the patient has to your intervention. That is a very important documentable thing. So in the three broad categories of the reaction, patient got better, patient got worse, patient did not change. Those are the three broad categories, and typically that's what you see on the patient care reports. Better, worse, no change. So improved, no change, or had some adverse reaction. So if those things do happen, you want to make sure you document that. If you gave a treatment and the patient improved, you want to make sure you document that treatment had some improvement, and you want to be specific about what the improvement was. If they had a negative reaction to it, you want to get real deep into that, as far as what changed, how it changed, and then what you had to do about that. So make sure that as you're doing these ongoing assessments or the constant monitoring, that sort of thing, that you're looking at those types of things and seeing how the patient is reacting, how things are changing. Vital signs will help you because the trending vital signs should be able to steer you in a direction one way or the other. If you think a patient's in hypovolemic shock, they should have a low blood pressure, a fast heart rate. They should be showing some signs of shock. You do your treatment, you give them IV fluids. Hopefully you will see some trends that show heart rate starting to slow down, blood pressure is coming up, and those signs of shock are going away. That's what we want to see. If you're not seeing that, then you need to document what you are seeing. If the blood pressure continues to drop, heart rate continues to go up, or heart rate also starts to drop, that's an indication of decompensated shock. So we should know that at that point. And then you should be doing some other measures. Maybe at that point you want to start a second IV, run, 2 IVs worth of fluids or something like that. Okay? Does that make sense to you?
Oh, yeah.
Okay. So take a walk through those 2 chapters this week. They've got some big words in them. They have a lot of those nice 50-cent words for you guys, which, if you don't believe me, listen to Derek. You'll see some of those on the test. So make sure you're familiar with those. Any questions before we get out of here? I've had our time limit here, so I'm trying to close this out and get out of here. The labs this week, we'll do some more of this. We'll talk some more about the 12 leads. We'll go over the cardiac stuff. We can show you some rhythms on the monitor, generate some for you, and do those types of things, as well as the assessment stuff and the vital signs and the reassessing. Anybody have anything before we go?
Nope.